Okay, so welcome everybody in the room, and also welcome to those online. As you, most of you will be aware, I think we run these clinical sessions each expo, so each October each year. This year we're doing one on SNOMED and cancer care. We have some really good speakers for you. We've tried to pull it together around some of the collaborations that we're doing around that are focused on cancer care, and also looking at the way SNOMED CT is used currently in implementations around cancer care. So it's a bit of a mixture of kind of both. I need to say that this session has been sponsored by the Vidal Group, just so you know, really. We're going to record the session, so as well as watching it obviously live, you can also catch up the highlights later, which will be good, I guess. So our first speaker, I'm going to introduce, you're the first speaker. I love it when you look at the speaker and they go like, I'm first, wait a minute. I think it's great. So, yeah, go up there, and I'll...
Oh, okay.
So I'd like to welcome our first speaker, who's Dr. Caroline Compton from the AJCC, the American Joint Committee on Cancer. And as I said at the start, they're one of our valued collaboration partners. So I'll hand over to Caroline.
Thank you. Good morning to all my friends that I haven't seen in years. I'm thrilled to be here to represent the American Joint Committee on Cancer. So I am an academic pathologist, and I know many of you from the College of American Pathologists, but I am here today to represent the AJCC and to celebrate the renewal of our partnership with SNOMED. And I have a few slides to inform you about what this partnership will look like and tell you a little bit about the AJCC in case you're not familiar with this organization. I'm going to talk about the mission of the organization, the big transition, I mean, after 50 years, the big transition from publishing a staging manual every 5 to 7 years and updating the staging systems that are used globally because of our collaboration with the UICC and the WHO. But we've moved from publishing a book that changed holus bolus every 5 to 7 years to a running update series that keeps pace with clinical need, clinical change, and also the needs of the surveillance community. So moving from editions of a book, of a manual, to versions of individual cancer site staging. And I'm going to tell you where this content is available. I wanted to start with our mission statement. So this is really how we see ourselves. And we revisit this mission statement on a regular basis. So we have a yearly retreat and we read this mission statement to make sure this still represents who we are. We believe that we provide, along with others, we provide worldwide leadership in the development, promotion, and maintenance of evidence-based systems for the classification and management of cancer in collaboration with our many multidisciplinary organizations who are core members of the AJCC. And we are dedicated to two goals, just as SNOMED is, to cancer surveillance in population health and to improving care for individual patients. This is a difficult mandate to meet because sometimes the needs of these two communities don't mesh very neatly together. And we have to make sure that we're not shortchanging either of our very important partners. So this is what I mentioned. when I started this morning, it was the big news about rebranding our products from a manual to a system. And the very first staging manual, AJCC staging manual, was published in 1977. So we are looking at nearly 50 years later to move from something that was rather static and not very evidence-based. So I used to attend those update meetings, and it was usually the loudest expert in the room who really got the most airtime, and their ideas were usually instantiated into the staging systems because we didn't have a system for reviewing the data that existed. It was very labor intensive and expensive, and at the time we had no means of doing that. So I hate to say, but the first editions of the AJC staging manual were more eminence-based rather than evidence-based. And we now continue to ensure that the staging systems are kept updated and evidence-based by a rolling system of review by expert panels that we recruit internationally, and we go through a process of not only reviewing the literature for a specific cancer site, but also the clinical need, which the experts would know about, because we don't want to become irrelevant. We risked that with prostate cancer during the 8th edition, and we don't want that to happen again. So we now release protocols, 1 to 5 protocols per year. So we have expert panels working simultaneously in these different cancer sites, and we publish these protocols in different formats, which I'll show you in a moment. I want to emphasize that our first mandate for staging was to measure the extent of disease. So in other words, we started out with our staging systems being just how much cancer you had and where it was. That was all AJCC staging told you. And now we want to include other prognostic factors and are doing that, especially in breast, so that we are taking relevant molecular factors that determine treatment protocols and outcomes, and incorporating them into the staging system. But I want to give you a heads up that we are already aware that this is an untenable approach, because the AJCC staging system is built on a mathematical bin model. So you have 5 different subcategories of T times 3 different subcategories of N times 2 different subcategories of M, distant metastatic disease, and that tells you, multiplying those 1 by each, tells you how many bins you end up with that would be defined as a stage grouping, which really is the proper terminology for an AJCC stage. But the moment you add even 1 extra factor with 2 different levels of choice, a yes or no, it's there or it's not, your bins start to explode. And in fact, in breast cancer, you can't keep the staging system in your head anymore, because we've exploded to some 768 bins. And so you really require a calculator in order to use AJCC staging, but we're building AI products that will allow people to do that. The 9th version of the disease protocols replace the protocols for the disease sites in the 8th edition manual as they become available. So some sites are very rapidly changing, updated with scientific evidence very rapidly, and other sites like, I'm a gastrointestinal pathologist, so it's all guts and butts for me, and there's some sites in my area like the ampule of water, I don't think that has changed in decades. So some of them are slower than others, and they remain as they were, or as they are now in the 8th edition. We do have requests coming in for version translations, which we hope to meet, and we have outside organizations who have already met that need. We did not perform these translations for the 8th edition in Chinese, Korean, Polish, Romanian, and Russian, but they are available on Amazon for the 8th edition, for the manual. And we set as a goal this dedication to ongoing communication with our partners so that we are supporting them to use AJCC staging in the way that benefits their organization and their constituency. So all disease sites have evidence for proposed changes now. And not only do we have these expert panels to which I alluded, who go through an intensive process of data gathering, review, discussion, endless discussions, meeting online once, twice a month for a year or even two, meeting with the Education Committee of the AJCC and the entire Executive Committee of the AJCC to make sure that everyone agrees. We don't want to change anything that will change systems for data collection unless it's really warranted and evidence-based. So the review of the data is formalized by professional, forgive the term, data jockeys. So we have people who go over the data that has been identified and brought forward by the expert panel, again, to make sure that the quality of the data on which changes are based is really high. And the overall cycle times for release are based on clinical needs. So we rush to the front of the queue, staging systems that have a great clinical need. And we also plan our work plan for the upcoming years based on clinical need. This is what the protocols look like online. They have a synoptically formatted data summary, which is color-coded here in T for primary tumor, N for regional lymph nodes, and M for distant metastasis. And we took our cue from the CAP and their cancer protocols. So we try to be as succinct and correct and clear upfront as possible with a synopsis. And then we provide extensive explanatory notes, again, very much like the CAP protocols for cancer evaluation in the pathology department. And we have a multitude of images, including line drawings, radiology, pathology images, and clinical images to make certain that the users understand exactly what we mean by a T13 determination. We have gone electronic, which is another big change in the AJCC over the last decade. We have AJCC staging content now, which is in our content management system and centralized, which we never had before. And that was quite a heroic task to translate everything from paper into an electronic content management system. And from there, we're able to control the quality of the product and feed it into 3 different areas. One is the API, which is our interface for our electronic health record vendors and customers. And so their systems are able to talk to our system, but we control the quality and the veracity of the elements, the data elements, and the staging elements that are being rolled over into the EHR. We also have our own website, which is AJCC Staging Online. And full disclosure, we don't yet have a calculator, which we intend to stand up, but you can go online and find your cancer site of choice. You can find all of the designations for the different TNM categories. These are for our individual physicians, cancer registrars, and any users of the AJCC content, including patients, because patients have now discovered what a powerful indicator of prognosis staging is. And lastly, our content management system interfaces with the Dynamic Link Library, or DLL, which is another interface for the cancer registry community and their vendors. So we're always updating centrally and pushing out peripherally to our partners. We have our products available on paper, as always. So you can still buy the 8th edition book and put it on your bookshelf. You can also download the individual paper copies of the protocols for the cancer sites that are completed and validated and put out officially through our channels. You can get the book, actually not the book, not the manual, but you can get the versions of the updated cancer sites in version 9 in e-book form. So this is a summary of what we turn out. And the 8th edition manual, the ebook of the 8th edition on Kindle, the ebook version of the protocols, the AJCC Staging Online, our API portal, and our DLL for cancer surveillance vendors. And those photographs included there show you what they look like. When you go online to find them, that is what you should expect to see. I just want to say, our content is available to our many authoritative partners, but we charge them for it, except for the government. So our partnership with the National Cancer Institute, for example, is a public service. But there's something that I wanted to tell you about our business model. We used to sell books, and that was the single revenue source that supported the AJCC, and it was one of the reasons why we couldn't really advance our products the way we wanted to. So we changed our entire business model now. We are an organization that resides within the American College of Surgeons as a program within the College of Surgeons. And this should be good news to you because we are not dependent on funding from the United States government, which, yes, I feel your pain. I was at the NCI for 7 years and can only imagine, and all my friends at the CDC and the FDA, my heart bleeds. But we do need to support ourselves. So we charge these fees in order to be able to keep up the high quality of service that we expect to be able to deliver to our partners and the rest of the international community. And SNOMED, our partnership with them, and their dedication to both surveillance and to patients will help us both do that. I think this is a win-win partnership of the first order. So we have renewed our agreement with the American College of Surgeons in order for us to switch over from book to electronic and all of the activities and professionals that we needed to do that. The American College of Surgeons fronted us the money, and it was a lot of money. We have since paid it back. So we are actually now in, we're not looking to make bundles of money. We re-infuse our profits into our product. And the renewed 3-year agreement advances both organizations' commitment to the diagnosis and treatment of cancer patients. Now, how does SNOMED use our information? This was a renewal of our agreement last May with SNOMED, and it's a bit tricky to be able to encode in SNOMED language all of the different definitions, yes, of T and M. I see all this nodding, and I acknowledge this. Of the T and M definitions in different disease sites. They mean completely different things. So they're also modified by suffixes. And for those of you who use this, you recognize that M is for multiple tumors, S is for a single tumor, F is for fine needle aspiration biopsy, SN is for sentinel lymph nodes. So we track back to the clinical scenario in which the data was gathered, so that you have some idea of how this patient was staged, and then formed using a T and an M designation into a stage group, which we then translate from data into prognosis for the patient. There are also other general concepts, I think I have it on the next slide here, of some other prescripts that we use to be able to qualify the staging, again, according to clinical practice and the scenario for the patient. And I want to point out that we have two different, the definitions are the same, but how the data is acquired is different. Clinical is staging using physical exam, observation in surgery, radiology. So basically, the radiologists are the most important players when it comes to clinical staging, but they're very shy about assigning a TNM, and we've had members of the AJCC from the American College of Radiology who have admitted that this is true. They even wrote an editorial for their own members called Stage Fright. They don't feel that they have enough hard information to be able to confidently assign, but in fact, they have the most information. Pathology staging comes from resection specimens. So we know exactly how deeply the tumor has infiltrated. We know exactly how many regional lymph nodes are involved, but we never assign M unless it is a validation by, say, fine needle aspiration of a big lymph node. And it correlates with the tumor that's been diagnosed. Now, we have a small Y prescript, which is staging after neoadjuvant therapy. And this is becoming a cause célèbre at AJCC. There's a working group for breast cancer, where almost all breast cancer patients are now treated neoadjuvantly. So we need to know what that means when we turn a staging after neoadjuvant treatment into a TNM. How does that alter prognosis? And so we annotate it with a small Y prescript, and small r It means recurrence. So after treatment down to no detectable disease, when the disease comes back and we restage it with TNM, we annotate that with the small r. So this starts to give you brain cramps because when we're talking to SNOMED, we're including all TNM categories used in staging determined by the stage classification, not separated by disease site. So it's this giant bucket of, I showed you there all the examples of valid values for T category. It's a lot, and they mean different things in different organ systems. It also includes all the valid stage groupings and suffixes, which I just reviewed for you. Examples of valid values for stage groupings would not only be stage 0, 1, 2, 3, 4, the classical, but also substages like 1A or 1B, and examples of valid values for suffixes, either added directly to the T and N categories or available as standalone concepts in SNOMED. There's a lot of work for SNOMED to interpret these in their own language. So after identifying SNOMED code, for example, a CT2 category, you, as the user, need to translate that back into AJCC language. So you need to know the disease site. You need to identify the year of diagnosis or recurrence, because that's going to determine whether you go to the 8th edition manual or you go to the 9th version protocol. And you, because it's based on the year of publication. And you have to go back to the AJC staging system to validate the prognosis associated with the stage group. This not only protects AJCC intellectual property, but it ensures that you're getting the right translation. We had a bad experience a few years ago where just entrepreneurs would start to build their own staging system apps, and they were full of mistakes. And so the only way we can guarantee the validity of this is to control the central source of truth. And this is just a small diagram to show you that depending on how the patient is handled, you may never get pathologic staging. If the patient does not go to surgery, the staging may be only clinical. If the patient goes to surgery, the path report on the primary tumor and the lymph nodes will supersede the clinical designation for those. And of course, if there's neoadjuvant therapy, then everything is shifted downstream to not only post-neoadjuvant therapy, but post-surgery and restaging. So principles are the principles on which we stand. These are free. So we want the marching orders for the use of AJC staging to be free to all. And this is the first chapter of the 8th edition, Principles of Staging, so as to have a cohesive approach to applying the TNM, and we go into some detail in the Principles of Staging chapter and the information online. These are the rules and guidelines to assure that everyone worldwide is applying the TNM in exactly the same way, so that the interpretation of patient management and for prognosis and for surveillance in the cancer surveillance community is done in exactly the same way. So AJCC website has the principles free for download, online. They're in the 8th edition manual and paper in chapter 1, and the version 9 protocols contain selected information that's pertinent to that website. So these are our products. If you care to search them online, that's the manual, that's the very first protocol on cervix that we turned out, but these are all the products that we are dedicated to maintaining as to the highest degree possible, their clinical relevance. We are all about patients. And we have our staging system online. We have the free Principles of Staging chapter that you can also get online. And so I just want to wrap up by saying that we're thrilled about our partnership with SNOMED because it allows us to disseminate the work that is from our heart and soul worldwide through a standardized and highly reputable global group like SNOMED. We believe that AJCC is the common language for cancer staging that we freely share with other staging organizations. We expand the usefulness of AJCC staging through our collaborations internationally, and our intellectual property is protected not only for our value system so that we are able to maintain ourselves financially and independently, which also gives us intellectual freedom, but also guarantees that there is a central source of truth and that we are dedicated to maintaining that to the highest possible quality for all of our patients worldwide. So thank you.
Thank you, Carolyn.
So you're not going to get away without questions entirely. I'm going to keep us to time, so we've got a section after coffee, the questions for the first 3 presenters for before coffee. So I'm going to save up your questions, but you won't escape, don't worry. So I'd just like to really echo what Carolyn said, but from the other side. So from the SNOMED side, working with AJCC, we have found very rewarding, and some of the reasons why I'll pick up in the questions after coffee. But I'm going to keep us to time, which for me is incredibly unusual. So with the staging, as Carolyn's just said, working through cancer staging, I want to move us on now to one of our other collaboration partners, which is UICC. So I'm hoping I have Dr. Brian Rouse and Dr. Susanna Tinbrun online. So at the moment they're backstage, but I'm sure they're going to join the webinar in a moment. Please. I know you're there, Brian, because I'm seeing you. This is always the fun when you work with technology. Never work with children and technology, that's the thing. So here we go. So Brian and Susanna, I'm going to hand over to you. So the screen is yours.
I'm going to start. Will my slides be displayed for me, or should I share my screen?
No, we'll show your slides. Yeah.
Okay, thank you. Good morning, everyone. My name is Susanna Tinbrun, and I'm a Global Resources Manager at UICC, at the Union for International Cancer Control. I can't see my slides. Yeah, okay. So the Union for International Cancer Control, next slide, please. We are the oldest and largest cancer organization globally, established in 1933. a non-governmental organization with a team of 45 based in Geneva, Switzerland. And we are a membership organization with over 1,100 members in over 170 countries and territories. We work with over 80 partners, including cancer organizations, private sector companies, and foundations. And we are in the official relations with the UN agencies, WHO, IARC, IAEA, and others. Next, please. What makes us unique is that we are the only global cancer organization representing all cancer types across the cancer control continuum. And we're connecting the most influential leaders, health leaders, governments, civil society organizations, and private sector through our activities and platforms. Next, please. Our mission is to unite and support the cancer community to reduce the global cancer burden, to promote greater equity, and to ensure that cancer control continues to be a priority in the World Health and Development Agenda. Next one. As I mentioned, we are a membership organization, currently with over 1,100 members, and these membership organizations span academic institutions, cancer centers, cancer patient support groups, professional associations, networks and alliances, and cancer societies. We don't offer individual membership. Next one, please. This is an example of a couple of our member organizations in Ghana, in Lebanon, in Nepal. Next one. Our approach is simple. We support the cancer community and we drive global impact. Next one. In terms of driving global impact, our current areas of focus, of course, as a membership organization, we work a lot on member engagement and support. But in thematic areas, we work a lot on access to essential cancer medicines and diagnostics. We work in the area of national cancer control plans and improvement of health systems. We worked with the theme of people-centered care. We have a specific focus on women's cancer, lung cancer since a couple of years, and of course, TNM cancer staging. Next one. You might have heard about UICC fellowships, a program that we have been running for over 50 years, but we also support the cancer control community for a variety of other learning and development activities. We run a community platform for our members. We offer online learning, different thematic training courses, virtual dialogues, conferences, and of course, the fellowships that I've mentioned. Next one, please. And we work by sharing knowledge. UICC produces the International Journal of Cancer, IJCC. We publish the TNM classification of malignant tumors and other publications, such as the recently published Cancer Health Systems and Control for Health Professionals. Next one, please. The reason why we're here today is because of the TNM classification, and I think it's important to highlight that this system has been developed by Pierre Denoy in France in 1940s and 1950s, and then adopted internationally in 1953. Professor Denoy brought it to UICC and formed a special committee on clinical stage classification in the 50s, chaired by him, and also became later on a UICC president. And this work evolved into what is known today as UICC TNM Prognostic Factors Project. The TNM classification became the most widely used cancer staging system worldwide, and we currently, this year, published the TNM 9th edition in July as a book. Next one, please. We also support the cancer community through a variety of events. We organize the World Cancer Congress, the World Cancer Leaders Summit. We are the driving force behind the World Cancer Day activities, and we have a new event as well for the cancer planners in countries called Cancer Planners Forum. Next one. Our World Cancer Congress is a big event for over 2,000 renowned cancer control experts, happening every 2 years and rotating across the world for a couple of days of interesting sessions spanning the whole cancer control continuum, and also featuring UICC members and their activities. Next one. Our next Congress is happening next year in September in Hong Kong, and the call for sessions is now open. So if anyone is interested to finding out more, there is information available on our website, worldcancercongress.org. Next one, please. As I mentioned, we are the driving force behind World Cancer Day, and that's one of the biggest health awareness days. And we lead the global campaign, and the current campaign is called United by Unique. And it's all about people-centered care. We have a variety of materials available on our website for everyone to download and adapt to their local context. Next, please. And it's our members who are making a difference on the ground in countries, making sure that World Cancer Day reaches millions of people every year and contributes to saving lives worldwide. Here's a couple of examples of our membership organizations uniting for World Cancer Day. Next one. And that's our team in Geneva this World Cancer Day in 2025. Next one, please. None of this work would be possible without our partners. As I mentioned, we work with over 80 different organizations, 80 different partners, from cancer societies, private foundations, private companies, governments, professional associations, UN agencies, but also international organizations such as SNOMED. Next one, please. And our collaboration with SNOMED International started as a response to a request from several European ministries of health who wrote a formal letter requesting inclusion of UICC TNM content in SNOMED CT to the same level of detail as AJCC. So when we heard about this letter, we were very happy with the request, and we followed AJCC's footsteps and signed a collaborative agreement in 2004. And we started a project with SNOMED on the inclusion of the content. My colleague Brian Roos will tell you more about the collaboration and the details of it. And this is all from me about UICC. If you want to find more information about the organization, on the next slide, there is our website address. And thank you very much.
Hi, everyone. I'm Brian Roos. You go to the next slide, please. So, yeah, I'm a GYN pathologist based in Cambridge in the UK. I also work closely with the cancer registry in England, which is the called the National Disease Registration Service. I'm involved with both UICC and AJCC. So I'm on the UICC TNM and Prognostic Factors Committee and co-editor of the recently published 9th edition. And I also on the AJCC editorial board and a member of the AJCC Female Reproductive Organs Expert Panel. Next slide, please. I just wanted to reiterate the beautiful thing about TNM stage. The principle is that we document anatomic extent of disease in a structured way by collecting things about the local tumor, the involvement of lymph nodes and distant metastases, and we can then combine those to assign a stage which is a simplified way of doing it and is generally in 1 to 4. If we go to the next slide, please. So in contrast to sort of non-TNM stage systems, having those separate T, N, and M allows us to really understand what's happening with the disease process and how far it's spread. So other staging systems will often put everything into, Professor Compton talked about buckets, but I've sort of used sort of a suitcase analogy here, but they'll put everything in, and so which can cause confusion. So if using those systems, you just know something stage 3, for example, you might not know whether that's because it's involved the lymph nodes or whether it's because it's extensive local spread. And other staging systems also start to include molecular aspects and things within there. So you might not know whether it's stage 2C because it's extended locally, or because it's got a particular mutation in P53 or a particular histological type. If we go to the next slide, please. So the approach that both AJCC and UICC take is to keep all these things in, collect all these things in separate suitcases or buckets, as you like, and so that we can and then group them together finally at the end. So just sort of follow on from Professor Compton's talk, wanted to sort of talk about how what the differences and similarities between UICC and AJCC TNM are. So UICC and AJCC work collaboratively on TNM, and both we take an evidence-based approach to improving TNM. So AJCC has access to the NCDB database, which provides a lot of the evidence for improving TNM. And through UICC, we work together with access to other international sources of data as well to provide that evidence. We also both work collaboratively with other groups, such as the IASLC, who look at improving staging for thoracic tumours, and UICC and AJCC have been broadly aligned since 1987. And between us, there's global coverage. UICC coordinates sort of national and regional committees, and so you can see that there's a broad coverage. There's geographical differences in where AJCC and UICC are used. AJCC is very dominant within North America. UICC tends to be used more in Europe and in LMIC countries. But there's different, it's highly variable across the world where both are used. Go to the next slide. So there's, as Professor Compton talked about, there are differences in the publications. So UICC has always published what was known as the livre de poche. So it's a pocket-sized book, was sort of originally designed so that physicians could tuck the book in the pocket of their white coats and have it easy to hand. Whereas the AJCC have traditionally published more extensive cancer manual, which you can see there, and more recently have moved to the system of producing individual versions rather than updating an edition. So that hasn't happened with UICC as of yet. So we've just published the 9th edition of the UICC livre de poche book. So there are some differences in the staging systems between UICC and AJCC. So UICC also includes a cutaneous carcinoma section, and AJCC include ocular adnexal lymphoma section. And historically, there have been differences in terms of the parathyroid, primary cutaneous lymphomas, and pheochromocytomas and paragangliomas, but they have been recently added to UICC. UICC also include essential TNM, which is a sort of a simplified model of TNM for use in low and middle income countries who may not have the same ability to collect the data. And we also endorse the childhood cancer staging systems, which are included in the book as well. There's a slightly different approach to morphologies between AJCC and UICC. AJCC lists morphological codes that are valid for each protocol, and so it's a prescriptive list that will include all the entities which are included within the WHO classification. And UICC tends to take a broader approach that states that the system applies to all carcinomas, for example, or melanomas, without actually giving specific morphological codes. So I wanted to talk a little bit about what stage is. So I've talked about how stage is disease extent, but is stage also prognosis? So if we go on to the next slide. So we can group prognostic factors into sort of tumor-related, host-related, environment-related ones, and I've sort of listed some examples there. And stage we would describe as being a tumor-related prognostic factor, but actually it is a very, very significant prognostic factor, so much so that it's almost become synonymous with prognosis. So so the next few slides, I've just taken some examples off my own cancer registry website. So If we look at stomach 1 year survival, so that, along the bottom, the net survival is on the y-axis, and along the x-axis are the stage groups. The different widths is to represent the different proportions presenting at that stage. But if you look at 1 year survival for stomach, you can see that the survival gets worse as you with the higher stage presentation. And if we go to the next one for bladder, you can see the same sort of pattern. And again, for colon is the next slide, the same sort of pattern. And that should be no surprise, because in looking at the evidence we derive for a stage, we are looking at the prognostic outcomes as well. So that's led to a slight difference in interpretation of the groupings for that we put in for stage. So although I'm saying both AJCC and UICC, we put things into individual buckets for T, N, and M. We do group them finally in terms of stage at the end. And AJCC uses prognostic stage groups, which includes non-TNM variables, and breast is the good example there, as Professor Compton talked about. And they may be useful in terms of aligning with treatment protocols and having a better alignment with prognostic outcomes. UICC takes a slightly different approach and concentrates on stage being tumour extent. This means that it's more easily applicable and in LMIC settings where they may not have the same access to the latest molecular technology. And allows comparison between countries which do have those technologies and those that don't. And it also allows us to look at early versus late diagnosis, which I should talk about in a second. So in terms of the TNM is designed to look at how the tumour progresses as it grows. And so we can sort of think of this model where as a tumour grows, it would effectively pass through each of these stages. This is an oversimplification because we know that tumours can go from 1 to 3. But broadly speaking, if you present early with a tumour, you'll have an earlier stage, an earlier anatomical stage. And if you present later, you'll have a later stage. And so if we go to the next slide, please. So in the UK, this has been used as a measure to try and improve cancer outcomes, with a target being set back in 2019 to diagnose 75% of cancers at stage 1 or 2. If we go to the next slide, please. So actually, you can see that we've been plotting this. You might think that this line is almost horizontal, but I can assure you there is a slight flick up towards the end, so there has been some improvement, but it's getting nowhere near the 75%. But it's a very useful public health measure to be able to look. And we not only do we look nationally, we look on regional levels and so on, and compare different communities and so on how the early versus late presentation can focus resources to try and improve that. Next slide, please. So some other differences with between UICC and AJCC. So we have some additional optional descriptors in UICC. So there's a descriptor for lymphatic invasion, which has been added to SNOMED as well. And then the next one is venous invasion. So similarly, that's also been added to SNOMED. And the next one is lymphovascular invasion, which is a sort of combination of lymphatic and vascular invasion. And so again, those parameters have been added to SNOMED for people to use. And then another more recently added optional descriptor is the H for heritable trait, which is used in retinoblastoma to indicate whether the genetic status of the affected patient. Next one. So there are some other minor differences between AJCC and UICC, which I won't go into the detail of, but I've just sort of documented there. And then the next slide. And then there are some other differences in some of the acceptable values. So one of the big ones is AJC doesn't include TIS for lots of sites. more recently. So anal canal, perianal skin, cervix and vulva don't include TIS, but they continue to be used in UICC. And LCIS, TIS, LCIS is not valid in AJCC, but it's still valid in UICC. So there are some differences. And then just wanted to talk about a few things in terms of UICC and SNOMED that we still need to address within SNOMED. So one, we have an optional descriptor for perineural invasion. The acronym for this is a bit unfortunate because it's a capital P little n for perineural invasion, and that's not the same as little p big N, which is obviously pathological lymph nodes. And so we need to look at how we can incorporate that into SNOMED without causing confusion because of the capitalization. And then the next one, I think there needs to be do some work in terms of additions and versions. So the 8th edition of UICC is included under sort of tumor staging level there, but we need to add the 9th edition. And I think we might need to look at a more intricated way of doing that, because I think particularly because of this, the difference between the publication systems now between UICC and AJCC, because so things that are in the 9th edition of the UICC may be the same as the 9th version of AJCC, or may be similar to the 8th edition of AJCC. And as AJCC progresses, things that may become the 10th version may or become the 9th version in AJCC won't be the same as what's in the 9th edition of UICC. So we need a little bit of work to align that. And I think being able to document that very carefully in SNOMED will be helpful. AJCC may also do minor updates, so things may shift from being the 9th version to a sort of a subcategory of 9th version as well. So I think we need to look at that. And then another thing that we're interested in UICC at looking at is so there are some other variables that are still in SNOMED that I think we may need to sort of look at sorting out. So as well as the sort of the main hierarchies for UICC and AJCC, there are some other sort of values around that we may want to look at and see if we can sort out. And then the last one I want to talk about is the optimum way of recording stage. So currently each of the values for stage in the stage hierarchy have parents that are the clinical stage or the pathological stage, for example. But it would be good to have a way of pre-coordinating that what that stage value you're talking about is either a clinical stage or a pathological stage, because they can mean very different things. And in sort of systems where people are just selecting one value, it's important that we know whether it's a clinical stage or a pathological stage. So in UICC, we had a discussion, and we think we would like to, rather than having a single stage 2, we would like to have parallel hierarchies of clinical stage 2 and pathological stage 2, for example. But obviously open to the experts at SNOMED about how best that can be, anything like that can be implemented. And I think that's the end of the session. Thanks very much.
So thank you, Brian. Thank you, Susanna. We're not going to take questions now because I'm going to keep us to time and probably kill myself in the process, but there we go. So I'm going to hand over to my colleague from CAP. I'm going to let him introduce himself. So Eric, the floor is yours.
Well, I want to thank everyone, first of all, for your time today. As Ian has said, I am Eric Daly. I am the Senior Clinical Product Manager for the College of American Pathologists. I oversee the implementation for the cancer protocols and the electronic cancer protocols. So my team is in charge of the software development that builds our single source product. which is what controls the creation of the cancer protocols and the XML-based electronic cancer protocols. Wasn't going to go into too much information here, as I'm sure we're probably running a few minutes behind today, so I'll save introductions to what the CAP is. I'm pretty sure most of you are aware of our organization being a pathology membership organization, but I'm going to dive right into the details of stuff that we've been doing with Dr. Scott Campbell with the implementation of SNOMED into our cancer protocols and electronic cancer protocols. So today's session, I wanted to call it Bridging Standards, and really integrating SNOMED into CAP is a blueprint for data interoperability. And I just got my first swear word for the day. You're not allowed to use the term CAP. It really is CAP, so my apologies on that. That's habit forming, so please keep track of that, and my swear jar will probably get larger by the day goes on. So for the agenda today, I really want to go over what I'm calling the CAP protocol purification. And then I want to turn it into something that Dr. Mary Edgerton had come up with, using this in real time with breast treatment. So we're going to go into that too. It's going to be a little teaser because we're actually doing a presentation on this on Friday. So Dr. Edgerton and I had kind of morphed our slides a little bit to give you some of the details today, just because I know some of you are coming internationally to see this presentation, but there will be more following on Friday. So we all know data is really important, obviously. We all know that in EHRs, a lot of that data gets lost. Structuring data has a tendency to help it, but it doesn't completely help it. So I like to think of it as data is like purified oil. If you can find a way to purify it, it is worth itself in gold. It's very hard to do that, and you have to clean it. So it's not just that, though. You also have to innovate the industry. And I think this is the step that we're at right now. I kind of look at it as from the horse-drawn wagon to the horseless carriage to the automobile. All those three things have one concept in common. They had an undercarriage. That undercarriage is what allowed us to go from that evolution in the automobile industry. I think we're at that stage now in data forms and extraction. We can get data, we can put it into our EHRs, but now how do we find ways to get it out very clean and easy? So this is the team that the Pathology Electronic Reporting Committee had created as their sub-team to purify it. You see Zhenju, Anna, myself, Dr. Ross Simpson. You're going to see Dr. Mary Edgerton in a second here. And then you're going to see Dr. Khoury, who is the chair of University of Nebraska Medical Center. They were very nice to allow us to meet with Dr. Scott Campbell and Mary at their organization, so I wanted to recognize them. And the time we had there, we spent about a week going through every single cancer protocol we had, purifying it with the SNOMED maps that Dr. Scott Campbell had created. For those who don't know, Dr. Ross Simpson is a very pristine photographer, and he uses 360 camera pictures, and that's what this is, so it's kind of a fun thing to put in. So steps to purifying our protocols. We actually found this week and a half event to be very astronomically important. It's really nice to sit down with a common ontology and actually look at like the like in the protocols, and you can really start to find inconsistencies. We noticed that one of our biggest things that we've done is we've broken lineages before in the past. I know Dr. Raj Dash is sitting in the back, has informed me of this in the past from an Epic implementation standpoint. But when you actually start looking at it over time, like we did, you really start to see how that really can hurt you. And I'm saying this today because I know a lot of us are starting to create these. I know that Polga has forms, and I know that ICCR does too. Trust me, try your hardest never ever to break a lineage history on it, because it actually really does hurt the concept mapping. We also noticed that things like treatment effect and extent and distant mets, they weren't always standardized across the board. So these were things that were great to do, but I think the highlight of this slide really is that we found that our PERT members needed to be involved in the content curation. This actually led to a whole new process CAP is doing now with our cancer protocol reviews. Our PERT members are actually actively involved in those review panels right from the start with the authors now. And in a few slides, you're gonna see that in some of our timelines. This is a busy slide. Bottom line is just trying to show you that through this process, we created over 150 project trackers, which is our way of saying incidences for our protocols and things we had to fix to get the purification to be exact. This is an example from the ureter renal pelvis. If you notice the margins involved by blank, we were missing the non-invasive there. So that had to be changed because our concept map had the non-invasive in it. The second one is margins involved by carcinoma in situ / non-invasive papillary. We were missing the hydrate. That was also mapped to SNOMED, so we had to get that completely fixed. In the retinoblastoma, we had 2 tumor extent questions. They weren't titled that way in our questions, but when we were mapping them, the map would say tumor extent. So we realized that it would be better to merge those questions together that were separate as one entity and use some nesting to get creative with it. This is an example from the vagina resection. In the margin section, we actually refer to answers for in situ hydrate dysplasia and low grade dysplasia. In the SNOMED conceptual model, what we could do is our observable entity for our questions, we could specify it specifically to cover those. And I don't know if you can see it on the screen, but the 3 different colors represents the same conceptual question, but it has different components within the SNOMED concept based on the answer it's going to be associated with. So it allows us to have mapping that's specific to the answers that are underneath it. And I think that's something that Dr. Campbell did very, very well in these maps, because it is very complex when you start getting into margins and some of the subtumor types. This is an example of distant METs. This would be more of the inconsistencies, if you will. These are things that Dr. Mary Edgerton and I were looking at significantly on these, because there's quite a few of them. But this is an example of thymus where we actually say intraparenchymal nodules. Well, isn't that the same as soft tissue is saying lung? And we started to realize that sometimes we have to maybe look at our list items and try to be more consistent, or use nesting to drive down answers that might be further identified. This is just some examples of ones that we had flagged in our spreadsheets that we were working on. In this particular case, I believe this is coming from TESTIREC or radiectomy. We weren't sure if endodermal sinus tumor was equivocal to the concept for yolk sac tumors. We had questioned it, but then when we went back to SNOMED, we realized that it is one of the acceptable synonyms, so we were able to keep that one. This next one is an example from the pancreas, where it's basically intramucinous papillary tumor. They didn't have an option for that, so Scott had to create one. So that's some of the work we went through to purify this. Tried to sum it up with some minor stuff. Currently, right now, we have a full map of the SNOMED concepts to the CAP cancer protocols. We are mapped up to our Q2 2025 release. We're actually going back in time now. Scott and I are flying a DeLorean back to 2018, and we have the CTs up through 2018 mapped. The next step is to get the Q3 2025 release done, and then we're hoping that's going to be either early this year, probably, early next year, and that'll be done. The next step for us, though, from development side is the CAP has prioritized a development project starting next year in 2025 for us to build out our single source product, the user interface, to actually house SNOMED directly in our database. Right now, we're housing them in a separate database. These will now be right in the SSP tool, so that when you're modeling and our PERT pathologists are doing the reviews, they could be selecting SNOMED concepts while they're doing the reviews. So I promised to bring back this whole entire part about PERT being involved in the process of authoring and reviewing. This is where this is coming into play. Our content curation consists of the cancer committee, our pathology electronic reporting committee, and then the staff at CAP. So we are actually now allowing all 3 entities to be involved heavily in this process, and SNOMED modeling is taking a precedence within this modeling as well. I actually just came from San Francisco from a cancer committee meeting where we were going over some optimization projects, and every time we're looking at an optimization, we're also looking at the ramification of what that could mean to the SNOMED map. This is our 13-week cycle for a release. This one's only 11 because this is the shorter. This is one that's for this next quarter, which is 2 weeks shorter. But as you can see, it's really complex and hard to get this stuff done. What we're trying to do is find time next to get SNOMED involved in this. And I have to give credit to Colleen Herbert from our team. This is her quite illicit and very strong QA process that she has built in. But the next step is really to find where can we integrate SNOMED mapping into this release process, which I think we can do it. I feel like it's going to probably come in the last review by the PERT members, because you're going to want to make sure that the content's pretty finalized in that process before you do it. So going back to the data being important and purifying the oil. This came up, and after we started doing this project, Dr. Mary Edgerton had an idea. And for those who don't know, Dr. Mary Edgerton used to work as a physicist in the oil industry, comically. And she's actually standing in the crowd today. So she had an idea of a project for this. And this project is going to be the presentation we're going to be giving later this week. I know this is going to make my PowerPoint look a little weird because we tried to integrate some of these slides into it, but I thought it was really cool to show this implementation, practicality. So her project was encoding pathology breast cancer data to determine pathological response to neoadjuvant therapy. So what does that really mean? It's a clinical pathological study that we're looking at breast cancer patients who receive neoadjuvant therapy. We wanted to aggregate the data from 3 major organizations. So in this case, we used University of Nebraska Medical Center, we used Northwestern University, and then we used Iowa University. We had to pipeline their data into an OMOP or PCORI common data model. And then from there, we used SNOMED extracts to look at the data for specifics in this treatment therapy. The goal of this was to extend this to international markets using Paul Seder's Polygon model potentially, as well as ICCR. We're looking at it from a clinical relevance, so we wanted to evaluate the impact on the patient's therapy, adapt treatments dynamically. Again, the idea behind this is if we can get this data faster and quicker, again, clean data, we can maybe dynamically change clinical perspectives on it. We can leverage the data for improvement and then also measure global adoption at success. For doing this, since this is North American, we use the CAP electronic cancer protocols, otherwise known as the ECPs. That's our forms, which we used for this one. This could easily be done with Polygon, done with an ICCR form as well that's mapped to SNOMED. We pulled their data from UNMC, University of Iowa Northwestern, from a common data model, and then started doing SNOMED extract queries on it to see what the results showed. This is just the schematic of how we started extracting this data. It's more just informatics-y stuff. If someone's interested in this, more than happy to sit down and show you guys how we actually were able to pull this. But this is the tool structure of how it works. So again, like I said, the CAP has a single source product, which creates that image in the left. That is SDC XML, that's the non-human readable format of our form. In the middle, you have a vendor's implementation. This one just happens to be mTuitives, showing the breast protocol being filled out. And on the right, then you have the database that it goes to in the EHR and how it spreads, breaks it out into a synoptic output and then a database table. What we're trying to demonstrate here is that with the pathology form encoded in SNOMED, it allowed for way easier extraction and assessment. And it also showed that if we're doing it this way, and if surgical synoptics were this way and radiology synoptics were this way, you really could have some powerful intercollaboration tools on this. And again, I'm going to go very light into these slides because Dr. Jones is going to be presenting this on Friday, and I don't want to steal her thunder. So for today's instance, I'm not going to show you guys the numbers, because that's really for Friday's talk, but I'm just going to show you what we were able to pull. So doing this, we were first able to get the number of total resections from all 3 organizations. We were able to get the neoadjuvant therapy, yes or no, done, and no neoadjuvant therapy done. We were able to assess pathological complete response. We're able to assess total receiving neoadjuvant therapy, complete response in breast only, partial or no responses, and we were able to get complete response in breast and residual disease in lymph nodes, which is pretty, from someone who used to work as an anatomic pathology director, pulling this data through Epic, this would have taken me probably a month to create a report out of the different various Clarity systems and Workbench edited reports that I had to do this. We did this in, I don't know, Mary, probably 2 weeks with 3 organizations. So it's pretty spectacular to be able to do that. Some of the lessons learned we found in this is that one for sure is that biopsy data missing is hard. And I would say for the North American pathologists, the struggle we have, at least in the US, is currently our accreditation requirements for biopsies is that they're not required in America. The biopsy templates house many of the biomarker templates, because many times you get that primary diagnosis when you're going to run a lot of your biomarker results. So that does limit your ability to find some of this information. We also noticed that ipsilateral and bilateral tumors, laterality in general is challenging. So make sure your queries can adapt to that. Not every template's gonna ask for laterality, or you're not gonna maybe have that as a finding to pull initially, but make sure you have that pull there, because it does help you to tell for some of the complex diagnostics. And then we joke about this, but there is the idea of the doctor other specifies. In your organizations, if you can try to deter people from using other specify, highly recommended, because once you start doing that, you lose the consistency of the data and the really the reasoning and point to have SNOMED encoding on top of it. From an informatics perspective, we were actually very impressed with the versioning system for the CTs. It actually really helped us to identify case timings. When we're looking at certain things, when people were showing me results that they weren't understanding, I could actually go back and say, oh, that was the breast version 3, and that's why we changed that, because we could tell by the CT, because the CT is versioned in our system. The other thing we identified is that the common data model serves the purpose of the pipeline, but when it comes to the computation of the pathology diagnostics, the SNOMED coding itself did that work pretty much on its own, which is actually really a big plus to SNOMED for doing this work for us through the SNOMED working project, because we were able to do most of the assessments purely just off the SNOMED, not having to use the common data model to have to, other than get the data in one place, support it. There's many contributors that I wanted to recognize for doing this work. These are many from our project that we're doing at the breast implementation, but there's others from CAP as well. And I just want to say thank you and remind everybody that coming up in the annual meeting for the CAP, there will also be another Cancer Data Summit that we also do in North America, and we would welcome everyone here to join us for that. And I'll leave it there.
Thank you. Thank you, Eric. Surprisingly, we're on time. I have no idea how that happened. It won't happen again, don't worry. I think, so from the kind of the first half of this session, if you like, I think one of the things which struck me and the reason for actually doing this session in the first place. So I've, as some of you will know, I've been involved in SNOMED for a long time. And one of the challenges we've had particularly prior to the collaboration agreements with both AJCC and UICC, was I'll call it the kickback, if you like, but from cancer clinicians almost coming back saying that SNOMED couldn't be used because they couldn't access the TNM codes. So I think one thing, just having access to those is almost fundamental. I do, one of the reasons for having Eric present as he has done, I think whatever we do in terms of tidying up the data, if you like, in SNOMED, unless it's got a practical use and somebody goes out and uses it, you do question why you're spending all your time doing it in the first place. But also, none of this stuff is easy, and it's not a SNOMED thing, if you like. It's a data thing and a clinical thing, and interrogating patient records. It's not easy, but it is worthwhile, because otherwise we wouldn't be doing it. So does anybody have any questions? Because we've got a few minutes before I let you go for coffee. So is there any questions in the audience? We do have a roving mic. Otherwise, I'm going to pick on my colleague in the front there, because he always has questions. For those online, you've already kind of figured it out, but if you've got questions online, just put them in the Q&A box and we'll ask them for you. Yeah.
So Carolyn, a question came, and this would apply for both AJCC and UICC. Do you know how and where the new SNOMED AJCC codes will be used by the AJCC? Would they be used at all?
I'm sure they will, but I don't know exactly how they will be incorporated. requires a lot of work by the two organizations together to make sure that the mapping is absolutely correct. So I can't answer that question, but I can say that we want this to succeed. I'm speaking for the AJCC and not CAP. Actually, I yes, because yeah, I was the chair of the CAP Cancer Committee when this all started, and it's come a long way. I'm very happy to say, but I don't really know the answer to that question. Sorry.
Okay.
You're gonna throw it at me. Speaking from the CAP side, I mean, we do use the non-pre-coordinated staging from AJCC in our protocols, and I say non-pre-coordinated because we keep our entities for the output restricted just to the PT 1, 2, 3, 4 or 1A, 1B. We do not put the definition into the diagnostic outputs in our ECP deliberately so we could actually make the staging maps more easily used. I do say that the vendors that we work with in our vendor implementation, I think are pleading for the AJCC staging ability in the maps to try to find ways to do that because they can, show onward use case from pathology down to their oncologist or surgical oncologist. So I think there is a use case there for the use of those SNOMED concepts for AJCC.
I think we have to think forward to the concept of anatomic staging that is morphing into this much larger concept of, stage tells you two things. The kind of tumor you've got and how much of it you've got, where it is and how much. It doesn't tell you anything about the tumor, and this is where we're trying to go. And even with breast cancer, which was way out in front, with being standard of care to do ER, PR, HER2, these were all very strong prognostic factors and modified outcomes to staging. And so we stepped out to combine these into the non-anatomic factors with the anatomic factors of being strongly prognostic. But you ended up, because it's a mathematical bin model. So if you've got 5 different subcategories of T and 4 different subcategories of N and 2 different subcategories of M, you multiply 5 times 3 or 4 times 2, and that's the number of bins that you get. And if you start adding on estrogen receptor, and that's only 2 bins, then you multiply everything again by 2, and soon you're up to 800 bins, which nobody can keep in their head. So we need an electronic format to make sure that happens, because these things are strongly prognostic, and we need a way to codify this. But right now, we're working on just how much tumor you've got and where it is.
So, thanks, Carolyn. It's interesting, and somebody has a comment. So from the pathology side, so it's a continuum of diagnosis, right? Whether it's clinical or pathologic and more. So when we started this project years ago to represent the data sets for the data sets for cancer resection reporting, it was collecting information about the atoms, if you would, of the tumor. Where was it? How far did it grow? What did it look like? How angry was the tumor, the grade? And so forth. Knowing that AJCC and UICC would create stages, which are indicators, right? I call it surgical shorthand. How bad is bad, and what's the prognostic? Because surgeons only can count to 4. Now, remember, pathologists can only count to 2 because it's either 1 or multifocal. No. Yeah. So we've all, from the IT side, we can all realize that physicians are mathematically challenged, and that's okay. But what we've tried to do is say we can collect this atomic information, these bits and pieces, and collectively they start to tell a story about the disease and the tumor. And based on how the bins are made, the bins can be recalculated based on what we understand today, based on the bits and pieces. So what we tried to demonstrate in SNOMED is that we can collect those bits and pieces and make them understandable, representative of what the pathologist in this case would say, that they could be calculated, if necessary, to create the surgical shorthand, or whatever is necessary. But then we can also reuse that data, not just to predict the patient's condition per se, but that type of patient. So what does a triple negative breast cancer patient with this type of phenotype of the rest of their tumor, and this is what Dr. Edgerton, her study will start to show, is this phenotype of patient, which now we can actually get the data without an army of postdoctoral students to harvest through a chart. How do they compare to this other phenotype? And would this intervention that might work for this class of patients that we've understood be efficacious for this other class of patients that we've just not had enough data to understand? And we don't have enough data to understand because it's so hard to go back and extract that data from the PDF, if you would. So the intent here is to take what the pathologists have said and the knowledge they've expressed at the microscope and make that accessible over and over and over again. So the goal is never to make more work for the pathologist, but is actually to encode the work that they are already doing and expressing that knowledge and making it usable. My joke with my pathologist colleagues at the university is you lose knowledge at the rate you are signing out your cases. We don't want that to happen. It took too long to gain that knowledge, and it takes too much effort to morph that into another pathologist in your residence. So can we speed that process and our understanding up? So Eric, thank you. Caroline, thank you. Brian and Susanna, thank you. I think we're getting close to coffee or even overdue.
So we're well, only by 1 minute. Give me a break. Give me a break, will you? So we go break for coffee for half an hour for those in the room, obviously, and those online. When we come back, we've allocated a quick 10 minutes if there are any questions. So go away and have your coffee, have a chat to some colleagues, and come back with some questions. Because okay, let's make a start. I'm going to try and keep us on time. We're only 2 minutes late. I'm doing fairly well today, which is most unlike me. So following on from the sessions that we had prior to your coffee break, are there any questions that has occurred to anyone over the break? Anything you'd like to ask any of our presenters? And I rather thought my colleague might be doing.
So Eric and Scott walked with me through the station to get here. And I didn't really reflect on where the trains were going, but I guess to put it in context, we might do that. But what we talked about as we went through the station was the extraordinary configurability of EHRs, and that virtually every hospital, or in the UK, every trust, even though they may have the same base system, will have a system configured to the requirements, and I put that in inverted commas, of the clinical staff in the hospital. In other words, they write in any old stuff they like by preference. And I think we heard a little bit of that from Carolyn, which, you know, when she was a young CAP chairman, she got shouted at because you did anything, you know, they wanted anything that you like. You couldn't do that. So my question is, how far are we away from really having a standardized implementation of, let's say, SNOMED in those systems, so that what you described about extractability is as simple as you put it? Because I have a sneaking suspicion you chose those 3 hospitals and it was all cool. But if you chose, you know, the 999 in the United States, it wouldn't be so cool.
Well, first of all, I think you're completely right, Charles. I mean, you're going to have some of your trailblazers, if you will, for organizations that are going to be ahead of the game. One of the things that we're doing at the CAP side is taking our CTs and also having a short GUID that goes with them that is consistent, stays consistent with the template throughout its lineage. I don't know if you guys remember my presentation, I said breaking lineage is one of the things that we've realized that has caused, conceptual issues downstream. So I think if we can utilize these SGUIDs with our CTs, it maintains a lineage for that template for its lifetime, which will allow organizations that maybe aren't as tech savvy to jump on board with this, because they can then use that SGUID from now until forever, and it'll translate to multiple CTs that the SNOMEDs are mapped to. I don't know, Scott.
Maybe just a real quick, there's some CAP speak in there. So
Scott will translate that.
yeah, now to translate. Okay. So the data set, we call them our synoptic protocols. More uniformly, they're called the cancer data set. So what is reportable by the pathologist? When we talk about lineages, we may talk about versions and restructuring of how something is presented. So here's an example. If you were a colorectal pathologist, a GI pathologist, you may recall, well, you already know, that how invasion into the vascular system works, right? And so you can have invasion into the large vessels, and then are those large vessels within the first two layers, I think it's the first two layers of tissue, or is it in the pericolonic fat area? And there's different outcomes associated with that. So all the important data to collect it tied to outcomes for the patient. But the question is, how do you present that and collect that data nicely and not make the pathologist click more things or fill more boxes out? So the College of American Pathologists used to have this nice structured if-then set of things, and it made it really nice, but then there was an effort to make the report more streamlined. And so if you would, it was all nested into a single question. So how do you do that? Well, what happened is little SNOMED speak here, but the context matters. So the question, if you would, the SNOMED concept carries all the context of the answer which you are going to give as a pathologist. So an answer, for example, of adenocarcinoma is great, but if I don't know the organ system where that adenocarcinoma is arising from, it's really irrelevant information other than the patient has some adenocarcinoma. So the question then becomes really important. Well, if the answer can be the invasion of the tumor gets to the lymphovascular space, well, that's this particular question, because we're going to talk about where that tumor is, and the answer is present or absent. Well, then the question carries that. Well, if in a synoptic, if there's just one section header, where does this tumor go? And there's all of these various answers. Well, we have to construct the SNOMED to be very precise, and how the question is presented matters. And so when we talk lineages, if you would, it's versions of the worksheet or the template, how it's structured. And Eric talked about something called a C key. All right, so little history. When the first synoptic reports were made, and Dr. Compton was there at the inception, it's her fault. She's still being tarred and feathered, as you would say. No, the Centers for Disease Control in the US said, well, can we get that information into our registries very nicely? And would SNOMED work? Or would LOINC work? Well, it turned out that the level of detail in SNOMED wasn't sufficient. So an inventory system of data elements was created. The C key is the inventory identifier. And so if you have the inventory sheet from the College of American Pathologists and you get the inventory number, you say, oh, well, this data element pertains to, large vessel invasion of the colon. But unless you had that super secret sheet, it wouldn't matter, right? Well, what Eric has talked about, and to your point, Charles, so the College of American Pathologists, if you would, has standardized the information model of how pathology data would be collected and stored. This is the cancer worksheet. The EHR vendors that implement that in the electronic format therefore have agreed that this is the information model. They can deploy that within their technology, but here's the information model and how you will encode and store this information, Epic, Cerner, Clinisys. And so, in essence, the society here in the US, the College of American Pathologists, has dictated how this would be done. And they've done that with, through leaders like Dr. Compton, getting consensus over a few years that this is what's supposed to happen. And look, we can demonstrate better outcomes to patients ultimately, and the Dutch have done that nicely, when the data is collected this way and can be acted on. So there's a long-winded approach to say the CAP has done stuff, and then they are continuing to develop the infrastructure that makes it deployable in electronic health records, and then to make it international, we put the SNOMED content on it, and now we can speak across borders because we all talk about the same thing. Go ahead, Aaron.
And one other thing to dovetail on that is we also created a vendor implementation program. One of my colleagues, Jim Durham, the last 8 years has developed a robust training process for vendors to implement these checklists into their systems. And that also is, I think, placated well to how end users feel this product. Since then, we've gotten quite an influx of end users because I think the product has matured faster now because the vendors are now more attuned to it. And that has a lot to do with Dr. Edgerton's chairmanship when she was in the PERT committee leading this process as well. So
there you go. So I think if it's actually with what
that might run it back what you were asking.
with the SNOMED International's recent description of how to engage, right? We do this great work, but who implements it? And so I think one of the charges that we who are involved in this work need to do is take it to the implementation level, train people how to use this. It's great that the codes are there, but who cares if you don't use them or don't even know how to use them? So CAP has had a nice example, and Polka has had a wonderful example as well in a different type of deployment climate. But I do think this is directionally where we're going, is in the bodies of the societies and the people who really actually care about the patients, are starting to dictate in a friendly sort of way. Like, you're a bad doctor if you don't do that. And you can't call a doctor bad unless you're another doctor, right?
Your edit button is gone and you can just say, do it.
Okay, I'm gonna move us on in the interest of time, and I'm not gonna, as a nurse, I'm not gonna tell any of the doctors in this room that you're bad. I wouldn't dream of doing that, otherwise I might get killed. So I'm going to move us on now. So online we have Professor Kieran Shin, who's going to talk about the ICCR, so the International Collaboration on Cancer Reporting. It's a SNOMED collaboration in progress, we'll call it. But I'll let Kieran kind of talk to his slides, not me talk to his slides. And Kieran, just tell him. Oh no, you're doing your own. That's fine. I was going to say, and I'll change them for you, but you're fine. You're in your own. Thank you.
So can you hear me, Ian? Yes.
We've got no sound.
You've got no sound, Kieran.
And we don't have any audio
Yeah, my audio is on here. Can you hear me?
Yeah, we can hear you.
Oh, great. Thank you. Thank you very much. And thank you very much, Ian, for the invitation. So my name is Kieran Sheehan. I'm a GI pathologist, like Dr. Compton, based in Dublin. I'm currently the president of the ICCR. And thank you to Ian for bringing together, I guess 5 key organizations: UICC, AJCC, CAP, ICCR, and SNOMED CT. I can't remember a forum where these organizations have been together and interacting. I'd also like to compliment the other chairperson. I can't see Scott, but Scott Campbell really, certainly in my work with Scott over the last number of years, has been the glue really that has driven this wonderful collaboration. And talk about Scott in a minute in terms of he is a serious champion of pathology, which is wonderful for us pathologists who tend to be generally hide behind the bushel. Most of you will be familiar with the ICCR. You can see on the screen what ICCR is, a global alliance of major pathology and cancer organizations developing internationally standardized evidence data sets for the pathology reporting of cancer. Now, that is just one of our 4 work streams. The incidence of cancer worldwide is significant, as you can see, 20 million in 2022. And of course, the concern is that this is set to increase, in particular in the low, middle, and income countries. So that is a concern, particularly in the likes of Africa and Latin America. And it's worth highlighting that the burden of cancer across the globe, but particularly in Asia. So ICCR is a true global organization. The history of ICCR is that the concept originated in Canada and Australia. In fact, our secretariat still sits in Sydney. So John Shrigley and David Ellis from both countries in concert recruited CAP and the Royal College of Pathologists together with the Australians and the Canadians. And this was the genesis of ICCR. And you can see it's grown to be truly worldwide. Now, there are gaps, particularly in Africa. Our 4 work streams are on slide here. So this is our core work stream on the left, the reporting standards. We're also really keen we're really keen to translate our data sets into multiple languages. We're very keen to implement the data sets into electronic health-based records and databases, and hence the value of SNOMED CT. And we also have a parallel stream of education. So our mission is to connect the major cancer authorities into a global pathology standard. And you can see our partners, just some or all. This is a key partner here, the WHO tumor classification, IARC in Lyon in France. We'll talk about that in a second. But I like to emphasize the role of the pathologist. I think a better term now might be diagnostic oncology. Clearly, it's not all we do, but the pathologist now has a significant and key role in terms of precision oncology. And you can see in detail what we do, in particular when it comes to molecular analysis. And that, of course, has translated into personalized medicine or oncology. So we start with an accurate diagnosis, but we do, if you like, watch our patients progress and or recur. But increasingly, we are predicting response to therapies, as alluded to by previous speakers. And of course, we're the great prognosticators, or not, depending. Structured pathology cancer reports certainly were seen early on, back in 2009. This is a paper from our founding father, John Shrigley. And the evolution then has been steady but slow from level 1 narrative, which a surgical friend of mine calls the weather report, to the advanced and achievable, hopefully, where all of our data, and as Scott has already said, and Scott is a wonderful champion of pathology, we'll come to that again and again, but where all of the data encoded, all of the pathology data is encoded in a machine-readable and standardized terminology. The users of pathology like this synoptic reporting. There is no question that the report quality improves, and we have demonstrated, that's the royal we in terms of clinicians and pathologists, that patient outcomes improve if one uses standardized structure reporting. This particular paper is in my own area of colorectal cancer, published by a Dutch colleague, Professor Iris Nachtigal and colleagues. So structured reporting has been adopted. Of course, we've heard from CAP already. The ICCR datasets are the core elements for the Australasian RCPA datasets. Getting back to ICCR, we have a governance which includes board of directors, which are listed here, and again we span the globe. We hope, and ultimately our vision is to improve outcomes in cancer patients and population cancer control through internationally standardized pathology reporting. We have an honorary advisory panel, so we have a lot of even at this stage. Founding of ICCR was 2011, and there's significant a memory in the organization, and we are tapping into that for former executive members. Our problem really, or our challenge, is that we have a shoestring budget. I will not elaborate, but we are almost entirely dependent on membership fees from the individual organizations. And unfortunately, pathology organizations worldwide do not have a lot of funding. Now, we do get donations from specialty societies and from cancer groups and from other sources, and we're in the process of trying to tap philanthropy worldwide, and that's an ongoing challenge for us. But you can see we have a good governance structure. This is our key committee here, the Dataset Steering Committee, but we also have a Structured Reporting Implementation Committee dealing with the detail of SNOMED, and Scott sits on that, for example. The impact of ICCR is as follows on this slide. So, for example, we have agreed to develop dataset templates in synchrony with the WHO, and this is key. This is currently ongoing, as you know. The WHO, the 6th edition of WHO is currently has started, and we're working very closely with Dr. Delani Locuchetti, head of WHO classification in IARC and Lyon, to ensure we're aligned with all of the work going on there. We've heard about TNM, and so I won't dwell on that for the moment, but only to say that we work very closely with AJCC and UICC to promote harmonization, and this is ongoing clearly as the various editions are published, whether it be in print or online. So ICCR sits here in that we interpret, I guess, the standards generated by AJCC, UICC, WHO, and the specialist societies, and we, if you like, translate them into our data sets using expert groups per organ system. We also are in the process of building strategic alliances with a large number of organizations, including those listed on this particular slide. And the benefits are pretty obvious, I think, in that we can use world's best expertise. We're a one world resource, and we have universality. And of course, this leads to the results as listed here in terms of what flows from these benefits. And again, we're concentrating today on the IT implementation and solutions that are out there. We have a very active website, as you can see here, which is used by most countries in the world. And of interest to you might be that 60% of those countries who use our website represent low middle income countries. Users in the last 6 months, I just highlighted the fact that you are in Belgium. I'm not, unfortunately, but so quite active throughout the world. So in terms of our current status, we currently have 62 datasets published, available freely from the website. This includes datasets for the top 10 solid tumors worldwide, 5 newer in development, and 24 existing datasets are being updated. More than 60 ICCR datasets related manuscripts have been published in peer-reviewed scientific journals. And currently, these are we have a large number of member organizations and affiliated organizations, as shown. We have we publish an annual report every year that's available on our website. So this is an example of a page from our website detailing the datasets published on the digestive tract. You can see the various organ systems listed here. And just to reiterate that there's a very stringent process of evidence-based discussion and analysis for each data set, and that translates into core items which are required and non-core which are recommended. So you see, for example, this is the colorectal cancer database, and the black are the core and the gray are the non-core. So this is the reporting guide, or the data sets with drop downs. And of course, we have, similar to CAP, we have the detailed notes that inform the various drop down items. So following on from the production of our last data set in colorectal cancer, we published this in the Annals of Surgery. And you can see a long list of authors here, again, which show wide representation from around the world. This gives us an opportunity, the likes of these publications, which I suppose come under the umbrella of education, to educate clinicians, surgeons. How do you educate surgeons in pathology, Scott, you might ask? But, you know, with photographs like this, I guess, which are courtesy of Phil Quirk in Leeds largely, which allows us to detail the current state of play with regard to the pathological assessment of rectal and colorectal cancer surgical resection specimens, with detail provided for interested parties. This is a separate data set that we felt obliged to produce, which is a polypectomy data set where one finds increasingly in the screening population cancer in polyps, and this has been modified. I guess the resection data set has been modified for this particular scenario. We're in the process of, in conjunction with the WHO, of developing 5 new data sets in the following organ systems: the appendix, gallbladder, anus, and liver metastasis. And we're also working on a significant project on neuroendocrine tumors, hoping to synchronize them with the updates into WHO classification of neuroendocrine tumors that's being worked on at the moment. So I'll move on to just say a few words about translation. So we think this is very important. We think it's essential to facilitate the implementation of standardized reporting worldwide. In particular, ICCR is focused on bridging equity of access to pathologists practicing in LMICs. We have identified 6 priority languages as listed here. We've done some work, it's pilot work, one might say, where, for example, the breast dataset suite has been translated into 6 languages and 2 variants as a pilot project, develop a model for future work and to explore challenges. And I'll say a little bit more on that in a minute. The American Society of Clinical Pathology kindly translated 21 of our datasets into Spanish, French, and Portuguese. These are available on the ICCR website, which I'll demonstrate to you in a minute. This used an ISO accredited translation company to undertake the initial translations. You'll hear in a second that this proved to be quite costly. Pardon me. Yeah, this is a page from our website showing the different language data sets. So this is the Portuguese, pardon my Portuguese, but this is the Portuguese for skin, pele. And when I saw it first, I could only think of one person, but there you go. This is the route to the cancer of the endometrium. And we have a very nice collaboration with a wonderful pathologist in the Ukraine, and he has currently translated the gastrointestinal data sets and is in the process with other colleagues worldwide of translating other data sets. You can see, I guess, the value of this type of work, and cancer knows no border, and of course cancer treatment has to continue in countries in areas of conflict. Lessons learned from the translation project have been that accredited translation companies are too expensive. Language variants are probably unnecessary. This is from John Strigley, so we don't need to worry too much about the variations in French, for example. AI systems, and particularly large language modules, will assist and lower costs. There's no question about that. But if you look at here, nearly accurate is not sufficient for us. So member organizations, pathology organizations, will be required to provide quality assurance on the translations. We're currently in a major project to translate all ICCR datasets into the German language. It's a joint project between ICCC, ICCR, German societies, including QUIP, and the Swiss and Austrian societies. So you can see it's a complex process with a lot of conversation, interchange, and so on. A number of collaborations are in development with, I did mention the Ukrainian, but also the Italian pathologists. ICCR continues to pursue collaborations with member pathology organizations, middleware, and LIS vendors to discuss opportunities for future translations. This is a survey performed by our current Vice President, Peter Schirmacher, former President of the European Society of Pathology, where the ESB asked what language of medical reports and diagnosis are typically written in your country. I was somewhat surprised, I guess. English is the primary language of medical reports only in Great Britain and Ireland. Maybe that surprised me, but there are likely 15 languages or more used, and this is just Europe, in reporting pathology cancer data sets. Some disease names are in Latin in some countries, and in fact there is one country or state that reports their cancer in pathology reports in cancer in Latin, and that's the Vatican. I promise not to bring religion into this talk, but I just did. I'll move on to implementation, and this is the core, I suppose, of what many of your audience are interested in. And the challenge, we created what we call a structured reporting implementation committee in 2021. Its scope includes development of electronic ICCR datasets, terminology development, harmonization of pathology, and cancer registry interface standards. And you can see it's been investigating structured reporting tools for LMICs for uploading into laboratory information systems. We have performed a survey of LMICs, which revealed that most pathologists reporting in major cities in Africa, for example, have access to LIS and internet connections, and half of the survey respondents use structured reporting in routine practice. The ICCR and SNOMED International have a collaboration agreement for SNOMED CT reference sets for all ICCR datasets to be available globally at no cost. The SNOMED CT coding of ICCR dataset project forms a key component of the collaboration with SNOMED and the University of Nebraska Medical Center. And clearly this will assist with standardization and interoperability of cancer reporting dataset data worldwide. And Scott Campbell sits on our SRIC. And this is courtesy of Scott, this slide from a presentation he made in Vienna recently. And you can read for yourselves there that the elusive level 6 encoding the data, and that this is the challenge. And I think the subject of a question just before I came online there, in how achievable is this? And we all hope that it is, but clearly it's not without challenge. And CAP are obviously well along the way to doing this with SNOMED. So yeah, and this is a publication from Scott, I believe. Walter Scott, isn't that right? And just published this year, where a fully defined, unambiguous SNOMED CT content is available for all solid tumors. Immunohistochemistry is included for prognostic tests. Pediatric tumors are included, and non-solid tumors to be considered. So, in fairness to Professor Campbell, no stone has been left unturned. And not only that, but in terms of foresight, I think Scott and I have had conversations about encoding cancer biopsies. I think this really is crucial. I gave a talk on this in Vienna recently, and interestingly enough, I think this was identified as a gap by our colleague from CAP. Now, there is precedent for biopsy data sets, you'll see, even within ICCR and CAP, but they are few and far between, unfortunately. And as Scott has mentioned to me, the rationale for doing this is that they're actionable, easy to implement. They do need to be concise and of better quality, and they have been, I think, ignored until now. But I think in the era of increasing neoadjuvant therapy, whether it be for colon cancer or breast cancer, as we've heard, I think we should put more emphasis on the large amount of data that we can extract from biopsy of cancer patients, whether it be morphology, H&E, grade, classification, biomarker status. Now, of course, that all depends on tissue. Tissue is the issue, and I keep telling my endoscopy colleagues to take surgical type biopsies. The surgeons are brilliant at taking much bigger biopsies, as you know. We make occasional jokes about our surgical colleagues, but they have no problem taking big biopsies. Our final strand is education. You can see listed here how we do that. Most important probably are our publications that we disseminate, and some webinars that we organize. So, for example, we've published 55 peer-reviewed scientific journals since the beginning of ICCR. We recently had a joint webinar with this organization on the pathology of cervical cancer and HPV vaccination. This targeted audience is in sub-Saharan Africa. The content was delivered in English and French. More than 5,000 people registered, and we did a live seminar attended by almost 1,000 people. And we've had a very active involvement with the European Society and IARC in terms of presenting at the ESP meeting on structured reporting, on the topic of structured reporting at the European conferences in the last number of years. And we're planning a joint session for the World IEP in Japan in 2026. And just to finish off then, why global engagement matters, you can see so significant inequity exists in patient access to high quality care, particularly in rural and remote regions, developing countries, and low and middle income countries. Global collaborative efforts are key to cultivate advances in cancer management. By standardizing pathology reporting data, we can optimize evidence-based cancer care for all, regardless of geographic location. So our impact listed here, which you can read for yourself, some I've already alluded to. So the Ukraine, Brazil, in terms of Portuguese translations, and some testaments from various different people and groups. This is a project under the auspices of the City Cancer Challenge Foundation and the ASCP, where ICCR data sets are incorporated into list systems in their projects, and a final project here in Africa. So thank you very much, and I'm delighted to take some questions.
So
Thank you, Kieran. Are there any questions for Kieran? And while you're thinking about it, do you want to add anything about the coding of the data sets?
Oh, sure. Well, thank you, Kieran. That was fabulous. And one thing that's really, frankly, special about the ICCR is its fingers everywhere across the globe, right? The cap represents a large body, right, in North America. There's a lot of cancer outside of North America. And what I find interesting is that how cancer is assessed is largely uniform across the globe. Some nations have more advanced sub-testing, if you would, but lots of microscopes exist in the world still. But what's fascinating about ICCR is its cap is on it, but its mission has always been lower middle income nations. But ironically, Europe has bound onto this, which is nice. And I would argue that Europe is not necessarily a lower middle income set of nations, right? But what's really great here is this just demonstrates that, and the ICCR has helped coordinate this, where cancer is really starting to be aligned by pathologists and harmonized on how it's going to be assessed, which then makes it very nice for informaticians, because we don't have to code chaos. We can code, not to say that pathologists aren't a little chaotic from time and again, but we can encode this. And so ICCR has just done a fabulous job of bringing these people together in a global way. And if you would, making these data sets very, very accessible, but also very standardized. So when we get to the standardization, that means we can start to make these digital, if you would. And that's where the coding comes into play. So what we're trying to do with the ICCR, as Kieran's mentioned, and Ian, so papers, been the commonplace everywhere, but in the world of electronic health records, paper isn't going to fly. So what we've been working on with the ICCR, similar to what we've done with the CAP, is that we're binding the terminology to all the data elements as represented in the ICCR and producing an electronic package. Right now, the intent is to do this at least in a FHIR type structure, a structured data capture package that could be picked up and dropped into somebody else's system, and then let them do what they want to do to their capability. But it's also something that's very lightweight. ICCR does not run on a large budget, so lightweight, easily moved. So these structured data capture packages are downloadable off the web, actually. So that's the intent. That's where the partnership with ICCR is going with SNOMED, and it's pretty exciting because I know that our European colleagues base much of the structured data sets off ICCR. So this helps a lot of people, I hope, sooner rather than later. Yeah?
Yeah, that's good.
Any other questions?
I've got
Charles, after you.
Hi, my name is Astrid Swinkels from Netherlands Comprehensive Cancer Organization. I just have a question. Nice work with the pathology structured reporting. I was just wondering, is it also going to expand to other areas like the radiology structured reporting or any other plans?
So funny you say that, although I don't see a radiologist in here yet. When I talk, I have no idea. I hope so. I know that it's been talked about. The American College of Radiologists has talked about it. When I talk with the chair of radiology, for example, at my university, they realize that they need to go this way. I mean, my argument is that there's only been one original radiology report. All of them have been copy and pasted ever since. That's my opinion of radiology, and then the word has been changed. So, but it does need to go there. In fact, even the surgeons are starting to look at that to structure their surgical report. Because I'm sure they're tying fabulous knots, but people don't really care about how the knot was tied. as long as it holds. But I think there are things that people want to know in the registries. That's a silly answer to a serious question. I don't know.
Well, I made the same sort of joke, which is, do you know any radiologists? Because the ones I talk to, it's a bit like what Caroline was saying earlier, that getting them to think synoptically away from textual renditions of what's in their mind has eluded me for as long as I've been doing this. They really don't want to structure their reports, and I've had no success.
Can I come in here if you don't mind?
We'll come over and learn from you.
Do you want? So, Kieran, did you want to respond?
Yeah, I'm very interested in this, particularly in rectal cancer, where it's proved impossible for us to get structured reporting on the MRI findings in rectal cancer, which is crucial for us now in terms of neoadjuvant in the neoadjuvant era. And I think it's ironic that the first TNM, as I heard this morning, was accepted, internationalized at International Congress of Radiology, and conflict of interest. But my son is a radiologist, and I keep joking with him that unfortunately, radiologists see things in black and white, pathologists see things in color. But the point here is that it is difficult for radiologists, I think, to provide an accurate TNM stage. That there are nuances that just I think the technology may be not quite sufficient, particularly in the bowel. Actually, CT scanning is not very good at T staging at all. Very poor, in fact, and even less so even in lymph node calling, lymph node positivity, and so on. So I do see the challenges, but nonetheless, I think if they at least began a process of radiology TNM, but it'll have to be RAD, I think the prefix wanted, as opposed to R. Yes.
And I was just going to say, one of the things, this is where it comes into the innovation to the vendors. I would challenge the vendors that you could have a synoptic input that a pathologist or a radiologist or a surgeon fills out, but that output of that form doesn't have to be in a synoptic. They could create those into a paragraph based. Like, that's the gloriousness of having it structured, is that it can go into a database structure, but they can put it into any type of contextual output you would like. If it makes a radiologist feel better, it's in a paragraph, they could put it that way. I mean, we're actually exploring the idea of having patient-centric records coming out of our synoptics potentially in the future.
Hey, I've got a question for you, Karen. So, wonderful presentation again. Question for you is from a pathologist perspective, and there's a few in the audience here too. I'd like theirs. So, arguing that biopsies are where treatment decisions are, well, the initial diagnosis is made, treatment decisions and treatment begins at biopsy. What do you think the appetite is from your peers to use some form of structured reporting at the biopsy level? And one alternative side comment, because that enables it to be structured in an electronic environment that can trigger all sorts of care guidelines and so forth.
Yeah, I think.
But I'm really interested in hearing what you think the appetite is. Or
yeah, Scott. Briefly, I think the appetite is there. Why? Because I think it will make life simpler for pathologists. Anything that simplifies our daily grind, as it were. I've been involved in a project recently where we have created structured template reporting for patients with inflammatory bowel disease. We've introduced that to our department 2 years ago. People love it. They basically just tick the code, DCA, disease, distribution, chronicity, activity, 1, 2, 3. It's a no-brainer. We can. So I think there's an appetite there, particularly with the workload going up every day in pathology departments, to have template reporting, structured reporting like this.
So in an inflammatory condition, not necessarily malignant.
Yep.
Because I know that there's been push for that too. I don't know if Dr. Edgerton or Dr. Dash have any comments on any, the use of biopsy reporting? Dr. Edgerton does.
So for one thing, with the increase in neoadjuvant therapy, if you don't have the biopsy in structured data, then you have to go back and find that. And if you have a complete pathologic response, a pathologic complete response, I got to get this right, a pathologic complete response, then you really don't have the information easily. The second thing I want to say is medical kidney. The Kidney Association in the United States was putting forth what they wanted to be basic core elements for medical kidney reporting. There's a large referral laboratory called ARUP, and they actually have several biopsy templates for non-neoplastic diseases. So there really is an interest, if for nothing else, than standardized reporting, but you have the benefit of being able to capture the data also.
So the problem is that it's duplicate data entry work for pathologists in the United States, and so no one's going to do it. Until the electronic systems can take one version, perhaps the synoptic with all the data elements is a superset of information, and then distill down the natural language version automatically. Otherwise, we're essentially doing both. So it's not mandated by the American College of Surgeons, and so it's not going to get done. So maybe, unless Carolyn does something that makes the surgeons do this. Right now, it's just the resection specimens, and already pathologists complain about it. How many clicks it takes to finish a report. Perhaps with the large language models that are being implemented by the large vendors now, it will become less of an issue, and filling out the biopsy will actually be more expedient and efficient than what it is today, where you have to do all the clicks for biopsy, and then you still have to write the narrative that most people are going to read.
Raj, do you think, do you think because I remember this decision having to be made at our university, either the synoptic report is placed immediately in the diagnostic line as the diagnosis, or it's post-pended. That was a design decision with our system, and it was a make it once forever. And of course, it was the typical install where the doctor would dictate or give the diagnostic line, and then subsequently a synoptic would come, versus your diagnostic line was the result of your points and clicks. Do you think that, and this is just really open-ended, do you think that would be?
So, I mean, however, I think clinical providers can get used to whatever format at their institution. The thing is, even the word synoptic isn't really synoptic. The narrative is usually much shorter than the synoptic, which is a long form. So it is a cancer protocol that contains a lot of detailed information, potentially, if you fill out all the recommended data elements along with all the required data elements. But the things usually relevant to a surgeon are like 3 data elements, right? The tumor size, the margin status, and the nodal status. And if you can sum that up in 1 or 2 sentences, that's all they would prefer to read, probably, unless they're looking for something in particular, like enrolling in a clinical trial or something like that.
So for biopsies, it's actually, because it's a shortened version and you don't have margins, et cetera, and I think that the synoptic reporting is actually much easier. However, what you have to do is say in your line diagnosis, see synoptic report. Invasive, and I'm a breast pathologist, invasive and in situ carcinoma, see synoptic report, and send people to see that. Where you place the synoptic report is very important, because the pushback I get is, oh, I have to go through all these different pages to get there. So I think that biopsies should be required, and whether it takes ACOS or AJCC to make that happen, I'm not sure. As for the longer resections, I think that what you could do is have an output tailored to the surgeon. What does the surgeon want to see? They want to see the margins. That's okay. What does the radiation oncologist want to see? All they want to see is lymphovascular invasion. I mean, they've told us that. Can you just put that up at the top of the report? So if you actually had a means of having the output tailored to who's receiving the information, you could probably be more successful in promoting it across the clients who receive it. It does mean that the pathologist has to put it all in, but we have to anyway because it's required for treatment.
Okay, I'm going to move us on in the interest of time. I am trying to keep the time. I'm doing fairly well.
You're doing very well.
Which is most out of character. So we've been talking about really the collection of cancer data. So now I'm going to take us on the journey to completely the other end. Well, I'm not going to take us. Our speaker's going to take us. So let me just introduce you. So Dr. Harlinda de Schutter, who's from the Belgian Cancer Registry. I'm going to hand over. So that way and that way.
All right. That's not manageable. Okay. Thanks for the introduction, and also thank you to the previous speaker, actually, because that's an excellent introduction to my talk. As said, indeed, I'm representing the Belgian Cancer Registry, which probably means we are located somewhere in the broad field, somewhere between the clinical field and also the public health authorities. So I will talk to you today about the current and future uses of terminology at the Belgian Cancer Registry, and we will mainly focus on the laboratories of pathology. So as an outline, I will tell you something more about the Belgian Cancer Registry in itself, about the coding systems that are currently used in our labs in Belgium, and then how we try to take a role in really putting structured reporting forward for pathology laboratories. Okay, so when you look at the Belgian Cancer Registry, we mainly rely on two data flows. On one hand, we have the laboratories of pathological anatomy, the other hand, oncological care programs. How many of these are there in our country? Well, surprisingly, a lot, okay? We have about 70 laboratories for pathological anatomy. They deliver both structured data, but also the full text reports of those pathology examinations. And altogether, per year, they represent more than 1 million records. Why is that? We do not only cover the classical cancer registration, but also receive information on all lesions for organs that are part of a screening program, which is, in our case, colorectal cancer, breast cancer, and also cervical cancer. On the other hand, as said, oncological care programs, about 100 in our country, and they deliver 130,000 records each year. Their delivery is based on what we call a cancer registration form. Importantly, by law, we have the permission to use the National Social Security number as a unique identifier, and that's really crucial to our work in order to be able to go back to the data providers, but also to combine the data with additional data sources. All right, so what do we receive exactly? When you look at the oncological care programs, this is the data set that we receive. You see here some patients, some tumor characteristics, but not very extensively. You also see some treatment elements, and actually they are very broad categories only. So what do we receive, for example, when it comes to treatment? A 10 represents surgery as a whole. This is not detailed enough, of course, to do what we need to do. That's why, again, we combine this with additional data sources. As for the diagnostics for the cancer, we use the ICO3 as the coding system. For the laboratories of pathological anatomy, these are the structured data sets. You see a separate set for the cancer diagnosis and then for the screening related lesions. So what do we capture? When it comes to the classical cancer registration, it's about all malignant lesions, so invasive but also in situ. all hematology oncologies, then all central nervous system tumors, all urothelial, and for ovarium also the borderline malignant cases. For screening, as said. And now, interestingly, the data formats that we use here are probably less known to you, being an international audience. So we use CODAP and also SNOMED 3.5 VF, and I come back to that later. As said, we also receive the full text reports, and it has been said before, these are fairly, let's call them prosaic. There is extensively interesting information embedded in those reports, and we would like to add that information to the data that we have. But as it is not standardized and also in 2 languages, being this country setting, we need to extract it either manually, which we do sometimes within the context of a specific project, but also we are using more and more the really AI solutions such as LLMs. Okay, so we get those 2 data flows at the cancer registry. The task for our local data managers is really to combine that information and to integrate it into one validated record for each tumor. You see that the overlap of the 2 flows is not complete, but that's explainable. You could have, for example, on the right side, a melanoma that is resected by a local dermatologist in his/her office. That patient will not necessarily be referred to an oncological care program if the resection is complete. On the other side, typically we have hematological diseases who are not necessarily seen in a pathology lab. So, but then taken together, what is shown here is really the core of our cancer registry. It's what we call the cancer registration database. And you find information in the database on the cancer diagnosis, of course. It's in this ICO3 format where applicable, and also includes TNM and vital status. This is the basis for what we need to do in terms of epidemiological reporting, but also in other tasks, for example, on evaluations of quality of care. I told you about additional data flows and linkages, and there are several of them. The most important ones you find here. So, for example, vital status information is obtained from the cross-flow bank of Social Security. That's really an accurate flow with about only 3-week delay. And also, we have reimbursement data from all health insurance companies in our country. So we use that to embed it in epidemiological reporting, but also in research. And you see here that we have several types of research. For example, a lot of work on quality indicators, but also separate from that other research work. I probably don't need to convince you that data quality is really at the heart of what cancer registration needs to be. It's about data quality in its several dimensions, accuracy, timeliness, completeness, validity, consistency, and uniqueness. And actually, this always has been the case for cancer registries. There is really an historical importance when it comes to data quality for cancer registration, as you see here in those landmark papers of Bray and Parkin. But it also means that we have a long-standing experience of using and adopting standards and classification systems. Now, let's talk about those particular coding systems that are currently used at our labs. As said, we have in the Flemish part of our country, pathologists using CODAP coding system. In the French part of the country, this is SNOMED 3.5 VF. Both systems were more or less set up in the years 1999, 98, and are based on, for example, CODAP, Letze-codes, and for SNOMED, the SNOP coding system. Both systems have been updated in 2017 in a collaboration between us, but also the commission, the local commission of pathological anatomy. And this update reflects the status of the Blue Books in 2016. How does it work? Well, the CODAP nomenclature system is based on 2 axes. You have the organ and the lesion axis. the organ axis is captured in 4 characters, which can include laterality, but also diagnostic procedures. And you see some examples depicted on the slide. For the lesion, we're talking about 2 to 4 characters, and that can capture, of course, morphology, but also differentiate between primary tumor, metastases, or also include additional codes, such as, for example, the HPV status. I think this illustrates that the system is quite mnemonic, it's quite intuitive, but it's also systematic. What about the CODAP, the SNOMED 3.5VF nomenclature system? Well, this consists of 11 axes, of which 4 are used at the cancer registry. Most important axes are topography and morphology. It's more or less resembles the ICD-3, but with some more details, especially for the topography, and in the morphology, you can capture some information on metastatic lesions as well. And then optionally, we can also receive information on the diagnostic procedure in the P-axis and some modificateur information, so additional information in the G-axis. So whenever a patient enters the hospital, several examinations can be done, or procedures if you want. You have biopsies, endoscopies, surgeries. So at each time, tissue will be removed. This means we will have several notifications for, in this case, cytology, resection, and then also lymph node material. So again, then it's our work to combine this into one tumor record and where applicable in the ICD-3 format. So in this case, it's a adenocarcinoma of the left lower lobe of the lung. When we convert to ICD 3.3, one code often converts to multiple variables. For example, in the CODAP case, the lesion will contain information on topography, histology, behavior, but also diagnostic procedure and differentiation grades. Same for the SNOMED 3.5VF. Morphology contains information on histology, behavior, diagnostic procedure. Well, this system really becomes less appropriate, and we have a need for a new coding system because the systems are no longer up to date with recent Blue Books. We also are facing ICD-4, and we know that the impact of that could be substantial. We would need to create new codes and remove others, for example. And also the systems are no longer supported or maintained by an official organization. So we need to make a transition towards a new coding system. We were wondering, should it be ICDO? Should we force the pathology labs to go towards ICDO? Or should we try to go immediately for SNOMED CT? And we had that conversation with the pathologists, and they agreed to try to go immediately for SNOMED CT. ICDO will not cover everything they want to code in their lab, and will also require some adaptations in IT systems. So why forcing them to a change if later onwards you want to achieve another change? How are we going to do that? Well, this is a familiar slide to you, which shows the levels of reporting in pathology labs. And you really see the different levels. So you have a range from narrative to structured reporting. The current situation in the labs is really a lot of heterogeneity. I can say most labs in Belgium are at level 2, 3 reporting. And the terminologies, as said, include CODAP and SNOMED 3.5. So again, we think if we would be able to achieve structured reporting, then immediately we could use SNOMED CT and lung embedding and also hopefully implementation into FHIR messaging. That would mean that you need some structured reporting software, which can look at such as here. So you have an interface, the pathologist will go through the menu and indeed click boxes. And then you have the built-in structured data capturing with the creation of the underlying database, preferentially, of course, in the right standards. At the site, you also generate a standardized report, which the pathologists like because they like being able to add some text themselves. How are we going to do that? Well, some initiatives have been taken by the pathologist community themselves, and they reasoned that standardized reporting could be a first step. They took the initiative to publish guidelines asking their colleagues to report in a standardized way for ER/PR, HER2, and also PD-L1. And they also asked us at the Cancer Registry to monitor the use of those templates. You see the results in the figure. What you see actually is for ER/PR at the left side of the panel, for example, separate results for French and also Dutch reports. Each dot is representing a lab, and what you see here is actually that it's very difficult to force laboratories to use standardized text. It's also time intensive for us, honestly, to just check whether there is some compliance. And we offered the possibility for labs that had structured data available to send those data directly. 2 labs were able to do that, and indeed they had an excellent data quality. What else did we do, or what else is happening in Belgium? Well, we have centralization of care getting more and more implemented in the Belgian healthcare landscape. And the cancer topic or type that is currently on the table is head and neck cancer. When you have those centralization exercise, it's really crucial to monitor quality of care by calculating indicators that of course also include pathology indicators. So within the draft text of the convention, it is already foreseen that there will be an obligation for structured reporting in time with a transition period for standardized reporting. So we decided to collaborate with the Head and Neck Working Group of the Belgian Society of Pathology to indeed help them to get those standardized texts using ICCR templates as a gold standard. We work in question-answer format and translate in Dutch and French, and then it's published on the BSB website, and we also foresee structured data tables in English for those labs that would like to deliver structured data. Just as an example here, so we start from the ICCR template. We create a report in Dutch and French with just drop-down options for the answer. And then as said, we also immediately foresee a standardized template or structured template, sorry, for the labs that have that potential. So they are already implementing that in their structured reporting software. There is also a bottom-up initiative that is, I think, very interesting. It's called BELS-Europa, Belgian Synoptic Reporting of Pathology. It comes from the pathologists themselves. Okay, they really would like to achieve general level 6 implementation. They chose a hybrid model with a central multidisciplinary development and maintenance of digital reports and a decentral implementation, so at the software and IT infrastructure level. They start from the principle collect once, use many times, which of course we very much like. And they are absolutely convinced that this will lead to correct and complete reporting. It could be a good solution for all stakeholders aligned with international development. What did they accomplish so far? They conducted interviews and surveys on barriers and facilitators for the implementation of this structured reporting, both at the pathologist level, but also with other experts. And they have conceptual plans, for example, to organize demonstration days for vendors of software systems to install a early adapter program. And they very much realize that there is also a need for a global roadmap exercise. They are looking for funding, could be public, but honestly, they are also looking at private funding possibilities, so from companies. Of course, top down, there are also some initiatives that really can help us moving forward. I think European Health Data Space could be a huge facilitator with its focus on standardization, semantic, technical interoperability. At the Belgian level, we see some vision coming up for primary use and secondary use, for example, in e-health action plans, but also some concrete initiatives. For example, they are developing care sets on vaccination, on allergy. They also have within the labs for clinical biology they have forced more or less those labs to implement FHIR within their information systems. And we can profit from them, as I will illustrate to you later. And they also have other projects, for example, on digital referral forms. So talking about FHIR messaging for clinical biology, we, as a cancer registry, play a role in the cancer screening programs. We support them, we try to monitor and evaluate them, or assist in that, and centralize the results. We recently had a change in the screening program for cervical cancer. We have now HPV testing coming first, then followed by cytology. This for us meant that we had a need for data retrieval for the laboratories of clinical biology. And by coincidence, there was this project driven by eHealth to indeed get FHIR implemented in the laboratories of clinical biology. It's called the Digital Lab. So we use that kind of report, and we developed what did not yet exist, for example, retam tables and LOINC codes. For us, this could be a long-term solution, but of course it also asks a quite heavy investment from our side. We also installed a multi-stakeholder group as a shared initiative between us and the pathologists. In that group, we have representatives from eHealth, from the Terminology Center, from Cienzano, from the pathologists, and also the Cancer Registry. We work in co-creation. We delineated 3 projects. The first one is really on the implementation of the structured reporting, acquisition and integration of the software. And in that context, we developed a business case as a discussion starter for policymakers. Then we also decided to develop a end-to-end use case that would need to fit the Belgian ecosystem and illustrate the entire trajectory. And maybe surprisingly, the pathologist community themselves opted for breast biopsy as a use case here. And then in the third project, we try to harmonize the order form also digitally. Everything is shown on this slide, so you indeed see digitization of the request form, but also the reporting in the structured reporting software, built-in templates with a exchange with the SNOMED CT register, leading to structured reporting and data that are tagged with SNOMED CT codes embedded in FHIR messages, and then can then be sent to several receivers. Of course, this needs governance on the template management, but also SNOMED CT coding, quality assurance, and this also needs a broader roadmap exercise as said. How are we going to do that for the breast biopsy? We start with delineation of the content. This has been put in the hands of the Belgian Working Group of Breast Pathology. It's based on ICCR, but with some adaptations. Maybe, unfortunately, they liked that, the pathologists. It will be translated in Dutch and French and aligned, of course, with other developed templates. It will then be translated to a FHIR questionnaire in collaboration with eHealth, and based on the SNOMED CT implementation guides. We will recycle FHIR resources where possible, of course. And then it goes to SNOMED CT binding with the Terminology Center for the Belgian extension, of course, of the preferred concepts. Then we would like to get to this early adapter phase with eHealth, but also the vendors, which we would like to involve early onwards, actually. It would be based on a digital protocol and start with a push phase. Then we have this testing and implementation pilot. And then we can go, hopefully, to the broad implementation. So we really hope that in this use case, we will learn lessons that will prove useful for this broader implementation and the broader governance and roadmap exercise. I think in conclusion, what I try to illustrate you is that I think cancer registries can also play a role in this ecosystem. They are assets somewhere between the clinical level and the public health level, but we really try to align what is happening bottom up with what comes or should come from top down. And what we are doing together should serve patients, but also general public, press, industry, and also research. This is exactly what is also meant by the European Health Data Space. So that's it. Thank you for your attention. Very open to any question.
So, do we have any questions? We don't online.
While you're thinking, am I on?
Yeah.
While you're thinking, I'll ask one. So in one of your slides, you talked about, I think, Belaropa or something like that.
Yes.
And where it struck me that maybe this was a recipe for allowing the naughty ones to be naughty. And is that the case, or is it just real politics that actually you can get 90% doing the right thing and you just don't care about?
We are talking about the early adopters, right? They are at the front line. You need them to push such kind of initiatives. It's really from the pathologists themselves. They have representatives of the major pathology associations in our country, and they are very, very motivated. And I think we are hoping that together with them, we could create some momentum to also have the back of the peloton, so including those 70 labs I was talking about, in this integration exercise, which will be challenging. But while you're doing that, and at the same time facing EHDS, and also being confronted with Belgian directives on, for example, SNOMED CT implementation, I'm quite hopeful. What you also see happening is that you have more and more fusions of laboratories. So that could also probably be a facilitator, I think. The most important issue is the IT part, of course, because we have a huge variety of information systems in our labs, including several versions, etc. What we see for the clinical biology, for example, is that the authorities are publishing directives that clearly state what aspects should be covered in the information systems that can serve the Belgian market. So that's how they see that. But still there will be costs that will probably be on the back of the laboratories, I'm afraid, yeah.
Fantastic. I'm sure Ian will give you a SNOMED badge to congratulate Belgium for choosing SNOMED in such a public way. Is there anybody else who wants to? No, Teresa Barry, but this is Ireland speaking.
Hi, Ireland.
Yes, so Teresa Barry is my name, and I manage the National Release Centre for SNOMED in Ireland. So I'm interested in what you're talking about purely from the terminology side of things. So you explained earlier that currently you use a lot of old SNOMED codes and the other ICDO codes. And so how problematic do you foresee that converting all of what you've been doing to now to SNOMED and that level of granularity? Are you planning on doing some sort of a feedback loop to kind of continuously improve, or just kind of your thoughts around that?
Yeah, I think it's unavoidable. We will, at a certain moment, to my estimation, we will work in several speeds. We will have the early adapters working with SNOMED CT, hopefully, but others that are still using the older terminologies. And indeed, we need to assure this longitudinality, the possibility to also over the broader period that we are covering at the Cancer Registry, to indeed be able to say something about trends, for example, over time, that do cover the pre-SNOMED CT period and this area. So yeah, I do think we need some alignment, and it will take time, and efforts.
And do you foresee, like, do you plan on taking what's been in the old SNOMED codes and the ICDO, looking, physically looking at all of those and then saying, do we actually have everything we adequately need now in SNOMED to fulfill what you require? And the only reason I'm asking is in Ireland, we've done some work on breast screening. So we've taken all of what they had in their old codes and converted them all into SNOMED, and there were gaps. Not everything was in SNOMED because screening is quite different from what you have typically in your in-hospital situation. There are other things you do in screening that you don't bring into maybe your pathology reports, but having that information may be relevant to your pathology report, what happened at the screening level. So I wouldn't underestimate the work.
Yeah, you're right.
Any others? Well, thank you very much indeed.
Thank you, Ollie.
You want me to?
So I'm going to let you wrap up. Have a final message. But do you want to use that, or do you want to? You need something to hang on to.
Yeah, exactly. So Ian asked me some time ago if I would try and summarize and talk a bit about what we've heard this morning. And I think the first thing I should say is thank you so much to all the speakers. You were really outstanding, all of you. Really interesting, thrilling stuff, I would say. And thank you to Ian for finding you. So I don't know how you did that, Ian, but obviously your network is very extensive. But I want to just reflect on two things. One is about humans, and the other is about urgency. And I do this occasionally, but I share my personal circumstances with people. And some of you will know this, and most of you won't. But 10 years ago, I developed a persistent cough. And I, like all doctors, in fact, like most humans, disregarded it. And that went on for 6 months until, in the usual way, my missus said, you better go to the doctor. So I went to the doctor, and to cut a long story short, I ended up being diagnosed with oligometastatic, which I'm sure has some sort of long PYT and dum stuff to it. In fact, I could find you the bit that it is poorly differentiated and no carcinoma of the lung. And I had platinum-based chemotherapy. I had a right lower lobe lobectomy. And I had stereotactic body radiotherapy to the metastasis in my thoracic spine. And the reason to tell you the story is, remarkably, I am still here and talking to you 10 years on. And that's my point about urgency. We've been talking in this way for 10 years about the amazing possibilities of data science and informatics. One, to explore why people do die, which is the emphasis that I think we've heard today about using those data to predict outcomes. But equally, I think there's a challenge for all of us to find out why I didn't die. Because you won't be surprised, in the conversations that I had with my oncologist to start with, he said, it's curtains. You're going to be dead by the end of the year. And most of the patients I was with at that time are indeed dead, but I'm not. And so I think the bit that I'm really interested in is how we use SNOMED CT and structured data to accumulate all of the data sets that you need to uncover why people get sick and when some people survive their conditions. And so it's not just about the pathology, the radiology, and so on. there's something about the social determinants of health and all the other things that determine your survival. I suspect I'm still here, either just purely out of luck, and that's probably the most likely. The other possibility is I'm a rich boy. I was brought up, you know, with everything that somebody could possibly want and need in society, and that determines largely your outcomes of health, whether you get sick or not. And so those elements seem to me a really important part of being able to link the SNOMED and structured data that we have for diagnosis with all the other elements in the EHR. And I think to a large extent, we heard about 90% of that today. And I would just leave you with that thought about, we gotta go faster. We've got to make that amazing collaboration of the 5 speakers talking either about their own countries or international collaborations or, you know, huge collaborations in the States, which the States, I suppose, is 52 countries, isn't it? Who knows what it is anymore, but it's, you know, it's going through a patch. But anyway, you're doing a huge collaboration and trying to extract that data, but my sense is it's too slow for humans. So the last bit I would say, one of the things that's made personally a huge difference to me is seeing those data in my personal health record that I can get to on my phone. That makes a huge personal difference to me. So those things that we heard about from the Belgian Cancer Registry and the ability to see those data personally at home and think about it really makes a personal difference. So I'll stop there. I hope I haven't spoiled your lunch, but I do think go home, do more, and work harder.
I just can't follow that. But the one thing I just wanted to say, as I said at the start, so these sessions we always record. They're always made available on the SNOMED International YouTube channel, so you can access them anywhere on the planet and everything else. And really to emphasize what Charles said, the whole area around cancer, around interoperability, around standards is important. There is an urgency to it. I suspect that in some ways we're preaching to the converted. So I'd be amazed if any of you in here are going, nah, all that stuff, forget about it. So we kind of accept that we're preaching to the converted. Having said that, all of you, so yeah, Charles has a bit of a dig about my clinical network. I do know a lot of people, but equally I suspect that all of you equally have your own clinical networks. So I always threaten to do this, but I'll use a catchphrase who Charles will know, but most of you won't. There's a comedian back in the UK, back from the 70s, early 80s, and his catchphrase was always, if you've enjoyed yourself, go and tell your friends. So in that case, in this one, literally go away and tell your friends and share it, get them to watch the YouTube channel. We won't stop here. We'll keep shouting about standards and SNOMED, whether you like it or not. So yes, thank you for your attendance. Thank you really very much for the speakers. You've all been exceptional. I've expected nothing less. And go and get some lunch. And thank you very much.